Thank you for your attendance here at the Research Boot Camp. Many of us here in the institution are excited at this series, and I think if you come and consistently come to this series, you will learn a lot more about research. Today, we're talking about applying research. It might seem backwards. It might seem the one we should do at the end, and maybe we'll repeat it then. But it tells you, or tries to answer the question, I think, basically, of why are we doing the research? We're doing the research, clinical research, so that we can apply that to practice and to patients and to the betterment of people here in West Virginia and, of course, throughout the nation and throughout the world. And so we're going to answer some of these questions. Why evidence-based medicine in clinical practice? Can we blend evidence-based medicine? Can we really blend the clinical research that we do and patient care and do that effectively? And what types of evidence are there? We're going to talk about the different types of research and different types of evidence that you can accumulate, that you can evaluate, or hopefully that you can do right here at West Virginia, and which are most useful in practice, and how do we evaluate that? Now, what is evidence-based medicine? The term came up in the mid-90s. It was, according to David Sackett, who was part of the McMaster group that masterminded this particular term, it is the conscientious, explicit, and judicious use of the current best evidence in making decisions about the care of individual patients. Now, those of us that trained in the 80s and 90s were a little surprised to see this statement because we thought we already were using the conscientious, explicit, and judicious use of the current best evidence. But as it turns out, about half the time, we don't have any evidence, and we're making an educated guess or making it up, but don't let that get out of this room. And the other half of the time, we were perhaps not as effective as we could be in evaluating the evidence and applying it to our practice. Okay? So the practice of evidence-based medicine really means integrating the individual clinical experience with the best evidence that we have from systematic research, and that was from Sackett and BMJ, the British Medical Journal. Now, this evidence-based medicine can really encompass a lot of different types of research. The most common type that you've probably heard about and that you hold in highest esteem, clinical trials, but there are many other kinds of research which are very important and which probably you have used and paid attention to and just may not realize it. It also goes beyond analyzing just, does this drug lower blood pressure or does this drug lower cholesterol? I guess that's what you'd call the old question and what we used to do back in the 70s, 80s, and 90s. Well, does this drug lower cholesterol levels? The evidence-based medicine question goes a step further and says, not only does a certain intervention lower cholesterol, but does it do any good? Does it help people live longer, have a higher quality of life? And so outcomes research was born out of evidence-based medicine. Now, why does evidence-based medicine even come up in clinical practice? In clinical practice, you just do what you do, and you walk around in the clinics and the highways and byways and do what you do. Well, it turns out that someone actually looked into this. Eli, back in 1999, published in the British Medical Journal, he said, well, how many clinical questions really come up that you really don't already have the answer to? And he found out that, interestingly enough, and averaged it out, there were 3.2 clinical questions that came up out of every 10 patients. So in a given day, there's a half a dozen or more questions that you sit there and pause and scratch your head and say, I don't really know what to do. And back before there were iPads and iPhones and Samsungs and things like this, it was a real problem. So you had to answer these clinical questions. And so the more common thing that I did when I was in practice in North Carolina was go down the hall and ask my partner. And then if he didn't know, we were in a real pickle. All right. The other thing that you need to do not only is learn how to treat people, but learn how to not over-treat them. For instance, in low back pain. It turns out that after really dozens upon dozens upon dozens of studies, and we'll revisit this in a moment, really one of the best things to do is to not do anything. And that's what the clinical research and the evidence-based medicine answer is. That your back hurts, say, you know what? The most common thing we say now in primary care and family medicine to patients is, well, it'll get better. All right. So sometimes evidence-based medicine doesn't have a really elegant solution. Now, what skills do you need? And we're going to talk about getting these skills today. If you were applying this in practice, you would need your individual expertise, and you're perhaps a clinician doing a residency program, and you're gaining that expertise. You've been in practice. And then you would say, but there's some things I know, but there's some things I don't know. And so the best external evidence, I mean, sometimes that is your partner or your nurse telling you, but sometimes you go to the literature, and so you need to use the best external evidence. But finally, you don't want to forget this third part, the patient's values and expectations. If you say, look, there's been studies about mammograms and there's evidence about it, and I know that mammograms are useful, I've found cancers using mammograms, and then you go in and talk to the patient. And the patient says, I don't believe in x-rays. I don't believe in mammograms. I don't think they do any good. They hurt. I don't feel like doing it today. So, despite the best evidence and despite applying it to practice and despite your individual and collective expertise, that patient may leave the office today without scheduling a mammogram. So remember that that's part of the equation. Now, what is a poem? Now, those of you that are Shakespeare fans may have a different answer to this question. But in evidence-based medicine, a poem is a patient-oriented evidence that matters. And without realizing it, when you peruse the literature for the answer to a question, that's really what you are looking for. You're looking for a poem. You're looking for not only the answer to does this lower cholesterol, but does this drug work better than that one? Does that work better than exercise alone? Does this medicine plus exercise work? Does cognitive therapy plus an antidepressant work better than either one alone? Or is either one alone good? Or is cognitive therapy better than medication? Or do I need to refer them, or can I just use this medication? You're trying to look in the literature, and you would actually have difficulty answering that particular question, by the way. But when you did, you would be looking for patient-oriented evidence that matters. You would not be looking for the mechanism of action of Prozac. You would not want to know if it helped mice run around the cage better. Although you would have to do that kind of research first, obviously, before the clinical research. But when you are perusing literature and you have a patient in front of you and they're waiting, you have to find patient-oriented evidence that matters. And there are actually books and journals dedicated to poems and have been for over a decade now. It's a focus on finding the clinical information that you really need at the time. It's just-in-time medicine. And now with PCs and handhelds and phones and little gadgets, we can find that information faster. Although we're suffering from not what we used to suffer from 20 years ago, as not being able to find it or not having the access, to actually having access to too much information. And that's why poems are still important. You have to find the right kind of information, even though you can find information quickly. Now, there's a hierarchy of research evidence. There's different types of research that are done, and they have different weight, I guess you would say, or hierarchy in the importance and the weight we give them, and the weight we give them in applying it to clinical medicine. Now, you'll be surprised. Let me ask you a question, and you can raise your hand and answer it. What type of evidence here is most often used in the examination room, in the hierarchy of evidence? Go ahead, be brave, it's okay. Which kind? Dr. Schrader? Help us out here. Which kind of evidence? All right. The most, okay, someone shouted out RCTs. Of course, that is the most common. No, that is not the right answer. The most common evidence that we use in the exam room is this one right here. Because more than half of what we do, we don't know exactly, because it hasn't exactly been tested. You say, well, pravastatin and simvastatin have been used, and we know they lower cholesterol and they lower mortality. You say, but what if someone has slightly elevated liver functions, they're over 50 and they're African American and they work in coal mines in West Virginia? Is there a study about that? No. There's not a study about that. Well, what if they also were getting some chemo, but they're done with that now, and so their liver was inflamed, but it's not inflamed now? Is that a risk factor, or how testy is that going to be? You can search PubMed high and low, and the expert opinion will be you and your partner. And you say, I don't know, what do you think? Well, yeah, why don't we go ahead and try it, and we'll just check their liver functions in a month. Okay, and who said a month? How about a week? How about something happens in 3 days? Maybe you need to check them in 6 months. Well, gee, how often should we check? You can search PubMed high and low. You will not find the answer. The most common answer is that there is no answer to your question. All right, now that we've got that, that's why West Virginia University needs to do more clinical research. All right, the next is case series and case control studies. The next in the hierarchy is cohort studies, randomized controlled trials, and then different types of appraisal or meta-analysis. And just for your enjoyment, we're going to go over all these today. Now, expert opinion is when conflicting evidence exists or when no evidence exists, and that is actually the most common situation. This is also why giant panels at the American Lung Association, the American Heart Association, the American College of Cardiology, and the cancer organizations get together and issue guidelines, because we're not exactly sure what to do. All right. Now, let's talk about the next one on the totem pole, the case study or a cross-sectional study. Now, before you poo-poo the lowly cross-sectional study and the case series, let me tell you that some very important things have been found out, such as that lightning is electricity. That was actually a case report by young Ben Franklin, and led to, obviously a series of events like us being in a room that has no windows and being able to see each other. So before you say that case reports are no good, they're actually the beginning and the building block of clinical research. So case reports and case series, there are observational large cross-sectional studies, large surveys with fancy names like NHANES and BRFSS. And it's a case study or a cross-sectional study if something happens at a given point in time. Now, interestingly enough, a survey that was done all year long is still a cross-sectional study, and that's sometimes a little bit confusing to people who are in it. It's like, well, it lasted a whole year. That's not a cross-section. A cross-section is, 1 second. Well, no, it isn't, because it was a slice in time in that person's life, and so at the moment you were talking to them, you were talking about how things were at that given moment in time, and so it's still cross-sectional. It may take you 2 years to do it and 6 years to write up your thesis, but it's still a cross-sectional study. All right. And surveys, these national surveys done by the National Center for Health Statistics at the federal level, and West Virginia does such surveys, of course, also. Those are cross-sectional studies. You may compare cases to controls, but these are actually very important and sort of the building blocks of epidemiology. Now, throughout today's events, I've chosen studies mostly done at WVU. I do not know who Dr. Miller is. He or she may be in the room right now, and so I hope I don't embarrass them by putting up their information here. I assume this is someone from the emergency department. They did a case series, and they were looking at the all-terrain vehicle accidents that came into the emergency department over a period of time from 1999 to 2007. And so it was a case series. It was over a period of time, but it was a retrospective observational study, so it's very well described what it is. And they were looking at, and they wanted to compare injury patterns of non-helmeted riders to helmeted riders. And they did that very thing. And they got these results that, in fact, non-helmeted riders were significantly more likely to arrive at the hospital via helicopter, and they were less likely to go home right away, as you might imagine. And so they documented an important epidemiological phenomenon that ATV accidents were occurring and still occurring, and that it's still important to wear your helmet. in these situations, you think they're safe and they're four-wheel instead of the three-wheel kind that we used to have before that, and so you consider them more stable, but still accidents happen. And it turns out that it makes sense that the non-helmeted riders had more head injuries and neck injuries. And so this was an important study, and it was a case series, and it was the building block for other interventions and outreach into the community. All right. Now, here's another one, and it used the BRFSS. That's the Behavioral Risk Factor Surveillance System. It's a nationwide study done by the CDC, the Centers for Disease Control. And it gives you state data and national data on a variety of behavioral risk factors in the population. And this one was looking at the health-related quality of life of residents in mountaintop mining counties. And so they were able to do this. Now, you may notice something very interesting about this kind of research. You say, well, this is the lowest building block on the totem pole, but they had to use Sudan multi-log and multiple linear regression with post hoc least squares analysis, things that most of we clinicians have no idea what I just said. Where it is on the building block in the hierarchy is not related to how difficult the statistics are to understand. It turns out that cross-sectional and cohort studies use some of the most sophisticated statistical methods, and they're actually somewhat harder for clinicians to understand the method, whereas randomized clinical trials is, well, you just count how many people got A and you count how many people got B, and they're actually much simpler to analyze. So the difficulty of the statistics and the hierarchy have nothing to do with one another. All right, so this was a very important study that showed that mountaintop mining, people in mountaintop mining and subject to that actually have worse health outcomes. All right. Now, what is a cohort study? A cohort study is like a cross-sectional study in a long line. No, not exactly. It follows people over a period of time, and it's an epidemiological type of study. It's a longitudinal observational study. The greatest tradition in science and scientific inquiry is to observe things. You go to a remote island off of Fiji and you observe the tiki birds and you observe that they mate, and some of them turn out yellow and some of them turn out green, and you write that up in a journal. That is observational science, and it is a great tradition in science. And when we do this in medicine, we have a cohort study, and we get together 1,000 of our friends or 1,000 people in a certain community and follow them over a period of time and see what happens. We see if they develop heart disease or cancer or injuries, and that's a cohort study. And you've heard of some of these: the Framingham study, the Women's Health Study, the Atherosclerosis Risk in Community Study, the NHANES, the National Health and Nutrition Examination Follow-Up Study, and many others. Many of the named studies, and they're named after towns or states, are cohort studies, and they follow people over a period of time. And you say, well, what good is that? You're just observing people. You're not doing anything to them. It's not a randomized controlled trial. You know, true science. False again. How did we find out about smoking? What kind of studies? Here's a clue at the top of the slide. Correct. Longitudinal cohort studies. We found people that smoke, and then we followed them over 10 years, and 10 years later there wasn't anybody else to study because the smokers were gone. All right. How many randomized clinical trials of smoking have there been? None. Zero. And how many are there going to be? So that's why people say, well, you know, you really haven't proved the harms of smoking using a randomized clinical trial. Well, we're not going to. And so you actually, of course, find out some extremely important scientific medical information using cohort studies. It turns out that when cohorts first began to be used in the medical literature, starting in the 50s and 60s and 70s, we found out, that's how we found out there was something called cholesterol, and it had something to do with heart disease. That was one of the first discoveries of the Framingham study. Diabetes in relation to heart disease. We said, geez, these people with diabetes, they seem to be having a lot of heart disease. We found that out from cohort studies and could codify that, and found out that diabetes itself is one of the largest risk factors for heart disease. This was all found out using cohort studies. And Dr. Luo, Dr. Joua Luo, and she might be here right now. I don't actually personally know her, but she's here at WVU. She looked at fasting blood glucose level and prognosis in non-small cell lung cancer. And so what she wanted to know is, do people with diabetes or pre-diabetes do worse when they have this kind of cancer? And if so, then we should pay more attention, obviously, to those patients. And this is the long answer to yes, they did. Patients with high fasting glucose levels had a 69% excess risk of all-cause mortality when they had non-small cell lung cancer. And so you can understand that result. But when you see these words like the Kaplan-Meier method, you say, well, you're going to see that a lot in cohort studies. It's called survival analysis. And you're going to see graphs like this one. And so when you're looking this up, when you're doing this kind of research, you obviously know what a Kaplan-Meier curve is. When you're looking at it and evaluating it and trying to apply it to practice, you're going to see something like this. Now, those of you statisticians in the room, this is obviously on a very basic level. For clinicians, which I am, you say, now this is something I can understand, folks. Now, which group is doing better? This is a survival curve. If you're up at the top, 100% of the people have survived. So which one of these lines, okay, the answer is going to be none of them. Which one of these lines would you rather be in? The blue line, the red line, or the green line? Okay? And you say, well, if I have to pick one, I want to be in the blue line. Well, that's the people with the normal blood sugars. The people on the red line are the people that are pre-diabetic or kind of borderline diabetes, and the people in the green line are the people with frank diabetes. They had shorter survival. It went down from 100% survival even more quickly. That's the kind of things that clinicians can understand. But when you see that, you can apply that to practice. And so you know if you're treating someone with this particular kind of cancer, and probably any kind of cancer, you can say, if they have diabetes, I'm going to have to pay particular attention to them to try to help improve their life and their mortality. All right. Now we can get to our favorite, the randomized controlled trial. Randomized controlled trials, we love them and we hate them because they're more difficult to understand than you might think at first. It is a type of study, it's a preferred type of study, but it's very costly. And the idea behind it, the reason it's called an RCT, is that you randomize people to one group or another, usually an intervention, people that have something done to them that we think is going to work or help them, and then the other group, the control group, the comparison group, sometimes the usual care group, or the placebo group. All right? And we randomize them. Now, why are they called RCTs, and why do we randomize them? What are we randomizing? I got some statisticians over here in the front. Let me listen to. What are we randomizing? Exactly. We're randomizing all the other factors except our intervention. And the plan of a randomized trial is that the only thing that's going to be different between them is that I'm going to give this group a drug and this group the pretend drug, and everything else is going to be the same. And how am I going to assure, I mean, some of them have red hair, some of them have dark hair, some of them have no hair like me. How am I going to assure that they're all the same, that they're metabolically the same? Well, we can't assure that. And so what we're going to do is flip a coin every time we see one of these people and put them in one group or the other and hope and pray and statistically assure that everything else will be equal. And so that's why we call it a randomized controlled trial, because everything else is randomized. So a common question when analyzing a randomized controlled trial, analyzing the results of a study, and say, well, yeah, but they didn't control for this. Yeah, but I think smoking has a lot to do with it. You know, I think hair color has to do with it. You know, I think people with long noses have longer cholesterol levels, higher cholesterol levels. And people will ask that question. And you, having gone to this session today, will say, that's part of the randomization. That should have been equal. And you say, well, how will I know? We'll say, well, you just check table 1. Because table 1 of every randomized controlled trial is a comparison of what we call the important factors, and they should be equal in both groups. The only thing that should be different is the intervention. All right. So here's a Dr. King at WVU who did a clinical trial, a very famous young fellow. Okay, not that young. And I, of course, used this as an example because it was so well done. And we wanted to find out, the objective of this study was to determine whether fiber would reduce levels of inflammation. It turned out that inflammation is the cause of everything, from cancer to heart disease. And that, interesting enough, that from previous epidemiologic studies, from cohort and longitudinal and cross-sectional studies, that people who ate more fiber seem to have less inflammation. But we said, like, fiber is mostly inert. Like, that's why it's called fiber. I mean, there's some that gets in you, but like, how could that possibly work? So we said, well, let's try it. Instead of just asking people how much fiber they eat and measuring their markers, we'll give people extra fiber, and we'll give the other people not extra fiber, and we'll see what happens. And so this was a randomized trial. And so we did that very thing. We randomized the people actually to get a little bit of fiber, 7 grams, a lot, 14 grams, or none. Now, in this particular trial, the placebo was nothing. We just gave them nothing. Because we couldn't find anything that didn't have any fiber in it to give them that would go into a pill form. Because placebos are made out of cellulose, and that's fiber. And so we couldn't give them a placebo pill. Interesting sideline. So there were results. And in this trial, in this famous trial, okay, it's not that famous. You haven't heard of this trial because it's what's called a negative study. There were no differences in the groups whether they had no fiber, a little bit of fiber, or a lot of fiber. And in any of the markers, any of the inflammatory markers. So we not only looked at C-reactive protein, the most famous inflammatory marker, but a host of others, and we couldn't find any difference whatsoever. All right. Now, when you look at a randomized controlled trial, and you're not supposed to read this, so don't panic, but you'll see this pattern. When you look at a randomized controlled trial, you'll see one of these box things, the trial profile, in most randomized controlled trials. And when you register your trial, you have to have one of these boxes. And it says, who are the people and what happened to them? Because up here at the top, you can't read it, but it says that we started out with 420 people that were screened to be in this trial. We threw out 249 of them right away. Then we ended up with 171 eligible persons, and we assigned them, the computer, the randomized number generator, assigned them to the groups, and it ended up to be 55 in one group, 57 in one group, and 59 in one group. And you say, well, that's pretty good for random. That's pretty even. So then some people said, oh, I don't want to do it. Some people tasted that fiber for a week or two and said, I'm not taking this for 12 weeks, no way. And some people, we lost their phone number and so forth. And so we ended up with, out of the 171, 158 people at the end. But you'll see a trial like that, and you want to know what happened to the people. We started out with a sample of 2,000 people, and we randomized 48 of them. And you say, whoa, 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 what happened to the other 1,900 people? You need to ask that question, and there should be a trial profile in the study. Because if strange things happen to them, I mean, you just can't believe the results. Then there's going to be a table 1. There's always a table 1 in a randomized control trial. If it's not, stop reading the trial. And there's going to be a comparison of the people that got the intervention. So it's going to say intervention and control. And you're going to look over to the right and see the little p-values. And the p-values shouldn't... This is one of those times when you don't want it to be less than 0.05. You want it to be 0.84 or 0.73 or point anything, but not less than 0.05, because you want them to be the same. Because you randomize them so that there would be no difference by chance between the groups. All right? And so that's what this is. You'll always, and I put this in here, you can see how well our scanner works in our department, so we need to do more research and get more funds. But what you need to know is that there's just characteristics along this side, and then the columns, and then you always look over here. And this says P.68, P.43, and so forth, because I told you this was a well-done trial, and that's the way it would come out. Then there's always a table of the results. And so whatever the factor is always over here on the left. And then the group that got the intervention, the group that didn't get the intervention, and then it'll tell you if it was significant or not. And so it's usually fairly simple. You just count how many people got A and count how many got the result in B, and you look at them, and if there's an even, I don't want to say a fifth grader could do it because, of course, it's a little more sophisticated than that, but you can usually tell the results of a clinical trial pretty easily. All right, so randomized clinical trials, the good. All right, first of all, it's the best we have. It's the gold standard. It's science-based. It reduces the influence of confounding factors through randomization. There's reduced bias, and the way you do that is blinding. If we're going to give you, we're going to do a trial of simvastatin versus pravastatin and give it to the people, we try to make the tablets look exactly the same, and then we just reach in there and we say, we're going to give you packet number 43 and packet number 44, so that the person that's taking the medication doesn't know what they're getting. And me, I'm giving it to you when you come into the trial center. I don't know what I just gave you unless I look it up in the secret code book that's locked in the safe. That's what the double blind is. Single blind is usually the patient doesn't know, but we know. I mean, it could be either one, but usually the patient doesn't know what they're getting, but I know. Now, the reason sometimes you say, well, why don't you just make it double blind all the time? Well, what if we're giving them therapy? Well, the therapist is going to know if they're giving someone therapy or not, right? Because they have to give the therapy. But the patient doesn't know what kind they're getting, and they don't know what the other people are getting. But when you're giving therapy, you have to know you're giving it. So there's some limitations, obviously. That's why all randomized clinical trials are not double-blind clinical trials. Sometimes you compare to no treatment or the usual treatment or just some other treatment. Sometimes you're comparing which helps you lose weight better, exercise or diet, or nothing. You can compare dissimilar things. You can compare surgery to medication. Many times, surgical procedures on coronary artery disease, we compare putting in a stent or doing surgery on your chest to giving you some medicine and follow you up for 2 years and see which group does better. All right, the bad. Now, I got to admit something. There's one good slide, and there's two bads. All right. Now, what's wrong with randomized controlled trials? They're the best we have. They're the gold standard. Well, they don't always find the answer. Let me give you an example. Low back pain. There have been hundreds of randomized controlled trials on low back pain. You can't do a randomized controlled trial and find the answer to every single question that we have, because what you have to have is a logical, reasonable intervention that you think will work. But before you can get to that point, you have to do a lot of research and do a lot of things to the cells and do a lot of things to the poor little mice and do a lot of things to the poor little rats and then do a lot of things to the grad students that volunteer to take that first pill. And you have to do a lot of things before you get to something that you can test in people and say, we're going to see if this really works. Well, in low back pain, we've done that hundreds of times. If you look in the Cochrane database, C-O-C-H-R-A-N-E, the Cochrane Review database, you can find out hundreds of trials in low back pain. And most of them don't work, and some of them work just a little bit. There are 35 randomized controlled trials of acupuncture in there about back pain, and the Cochrane's conclusion, not mine, was that we just can't really tell if it works. Then you say, well, maybe if we talk to the people and explain to them and have them do exercises and talk to them about stress, maybe that would help. Well, it really doesn't make much difference. And you say, well, chiropractors, they say it works, and they have people come in, and there's people coming in and getting paid to do chiropractic care on their back, and there's some people in this room that have had it and would swear by it right now. But as far as the randomized controlled trials, we can't find any difference. And physical therapy, which is what we do and we do here at WVU Healthcare, is minutely a little bit better than just going home and walking around. So there's really no good treatment for back pain. So randomized controlled trials can't give you the answer to every question because they can't invent a new therapy that works. You have to have a therapy that works before you test it in a randomized controlled trial. All it does is tell you that it works. It doesn't create it for you. You have to remember about that. Randomized controlled trials can be very expensive. So we're going to find out if immediate treatment for stroke and giving you a clot buster when you come in for stroke, if you come in within 3 hours, we're going to find out if that makes you live longer. Well, first of all, you have to find people that come in within 3 hours of having symptoms. Then you have to have all the testing, the MRI scanner, the CAT scanner. You have to have neurosurgeons available. You have to have cardiologists available. You have to have the clot buster available. The clot buster stuff costs like $20,000 for one squirt of the stuff. And then you have to have a network of people. And you say, well, and then you have to say, well, how often does this happen? Maybe something like this only happens like, I don't know, once a week, once a month, that come in with these exact criteria with the person with the exact age that doesn't have certain comorbidities or other illnesses. It turns out that sometimes that can be really expensive, and you have to involve 37 other countries and 106 other medical centers, and when you do that, obviously, sometimes randomized controlled trials that you read about and you throw in the trash right before you get on the elevator cost like $10 million. And it's sometimes difficult. It's sometimes difficult to find someone to take no treatment once there's a treatment available. And I'll give you a little example of that from my own experience. I was doing not a multi-million-dollar trial in multiple countries. I was trying to see if erythromycin would help people with bronchitis. Now, the CDC and everyone you know, because this is what they think, and it's the expert opinion, says that bronchitis is caused by viruses, and antibiotics don't do any good. But if you ask any patient that took an antibiotic for bronchitis, they will say, "Thank you, doctor, I got so much better." But there, at that point, was not one randomized controlled trial that showed that antibiotics would do any good for bronchitis. So we say, well, we're going to find out. That's fairly simple to do. We're going to randomize the patients. When patients come in with bronchitis, we're going to say, sign this form, and we're going to give one of them the antibiotic and one of them the placebo pill. We're going to see them in a week. Each day we'll have them write down a little log book how they're doing, how much they're coughing, and how they're feeling. This is the simplest thing. It's like falling off a log. There's only one problem. Despite the fact that everybody knows that antibiotics don't work, when we presented this to the patients, we said, oh, you're either going to get erythromycin or nothing. And they said, well, I'm not taking nothing. I'm sick. There's no evidence that antibiotics help you, but all patients believe that. And so it took us 2 years. Now, we see like 10 patients with bronchitis a day. It took us 2 years to accumulate 50 patients that had bronchitis, which really meant we only found 25 that were willing to take nothing. And I'm not sure they took nothing, because they must have snuck out and gone to urgent care the next day and taken it, because we found no difference between the two groups. It was very hard to get someone willing to take nothing. If you do cancer research, you know this is a very challenging area, and it's an ethical area, and it's a scary thing. If you have cancer and you say, well, there's this other thing that it will give you 3.7 years to live, and there's this other thing, and we'll add another drug to it. And we don't know how that works, but it'll be in addition to it, but of course it'll make you a lot sicker. Do you want to try that? And you're like, I don't know. I mean, very difficult. So randomized controlled trials, while the best thing we have, it doesn't mean it's easy. Then there's overgeneralization of the results. Oh, I saw this trial where exercise was better than diet, and so I don't even care what I eat. I just exercise all the time. Well, wait a minute. You might be overgeneralizing a little bit. That was only in 16-year-old girls who were, whatever. You have to make sure that you don't overgeneralize the results from one study or one small group of people. And finally, there could be improper randomization. The sample could be too small. Maybe they broke the blinding. Maybe there's dropouts, etc. So once you have these and once they're well done, you apply them to your practice, and they turn into a patient-oriented evidence that matters. Is the condition relevant? This is how you decide if it matters. Is the population like mine? Was this done in people in Minnesota and New England, or was it done in African American patients in South Carolina? Which is your patient population? Is the therapy reasonable? Let's say, well, yeah, that's great, that works, but that's $100,000 a dose, that stuff, that's a great antibiotic, but that's a little pricey. Is it patient-friendly, too costly? Are there side effects? Is this just one study or one of several supporting? Are there other alternatives? All right. So everyone knows that vitamin C is good for you, and everyone knows that they're antioxidants and they should help you. And so the recommendation, expert opinion, in the 90s was that you should take vitamin C and vitamin E, and it will help you live longer, and it'll help you keep from having oxidative damage and progression of atherosclerosis. It'll stop you from having heart attacks. You just take vitamin C and vitamin E. Because people that take vitamin C and vitamin E and have higher levels appear to live longer. And they're the most prevalent. The supplemental use of these vitamins, I mean, this is a slam dunk. Everybody knows this. And we were teaching all of our residents in the 90s and early 2000s that, I mean, you should recommend that your patients take vitamin C and vitamin E. Until we did a randomized control trial. And we gave them vitamin C and vitamin E. And vitamin C and vitamin E didn't do anything. In fact, it made some of the people start to bleed. The outcomes were actually worse in the people that got this little simple vitamin that we had given people. And so, oh my gosh, despite these data, randomized controlled trials failed to confirm. So this was a very useful randomized controlled trial because something that we thought worked, in fact, didn't work. And so sometimes we find things that work, and sometimes we find something that didn't work. In lipids, we said, well, lipids are good for you, but I don't know if you should take them that long, right? So the heart protection study said, well, let's follow the people out for 11 years, even though it was only a 5-year study. And they said, you know what? It's still good. It's still good after 11 years. And so they've studied it as long as most trials ever go on and twice as long as most trials go on. And they say, you know what? If you lower your LDL, your bad cholesterol, and you just keep taking that stuff, it's still good. It still works. It doesn't wear off or nothing bad seems to happen to you. So that's a very important one. All right. So we've worked our way through expert opinion, case control, cohort studies, randomized trials, and now we're working our way up here to reviews and conglomerations of evidence, I call it. I hope that came through on the recording there, the conglomerations, because that's new. All right. The meta-analysis. A meta-analysis is a statistical technique, but it refers to contrasting, combining results from several studies. Now, what if there were studies of a new drug, an antibiotic for pneumonia, and they tried it on 24 people in Boise, and they tried it on 36 people in Sweden, and they tried it on 59 people in Washington, and 93 people in New Zealand. You say, well, I don't know. I mean, none of those studies was big enough for me to start doing it in my practice. But someone in the statistics department would say, you know what, if you could just combine the results of all those put together, if the patients are similar enough, we'd have one giant study with 400 people in it. And if there was a big difference, we could find out if antibiotic A was really good for you. It's most useful when randomized controlled trial results are clear, or not clear, or when they're conflicting, or when it just doesn't seem like the studies have been large enough. And so, here's an example of people with low risk. So in other words, does lowering your cholesterol do any good? We know it does good if you just had a heart attack, or if you have established heart disease. The question is, should we be giving a drug to people that are at low risk with nothing wrong with them? Does it still do any good? I mean, some people just say, yeah, I just think we should put statins in the water. And they say, well, hold on a minute. We need to check that out. So they did a meta-analysis of 22 different trials of statin versus control to see if people in the really low-risk groups still benefited from being on a statin, even though they didn't really meet the indications. And lo and behold, the results said that for every millimole per liter reduction in bad cholesterol, it reduced your risk of vascular events about 11 per thousand or 1 per 100. And this benefit greatly exceeds any known hazards. It says, well, wait a minute, it does good even for people at low risk. And so maybe we should start rethinking that. Another one by Dr. Kelly. Does anyone know Dr. Kelly? George Kelly? Wonderful. Okay. Dr. George Kelly did a study, and he said, does walking do you any good to lower your cholesterol and help you do better, no matter what size you are? All right? And he found that indeed walking reduces your cholesterol independent of any change in body composition. In other words, if you're walking, it's doing you good and it's lowering your cholesterol and it's helping you be healthier, even if you don't change pant sizes from starting your new walk program. Okay? So some people say, well, this walking is not doing any good. I didn't lose any weight. I'm going to stop walking. And Dr. Kelly would say, no, keep walking. It's doing you a lot of good. It's reducing your risk. It's reducing your cholesterol, even though you didn't lose any weight. Now, I wanted to show you this because this is the kind of result you'll see very often in a meta-analysis. Each of these little lines is a trial, and this is the result of that trial, the big dot, and the confidence interval, or the variance that includes 90% of the time. And what you do is you look at the 0 line and you say, yeah, if most of the big dots and most of the things are over here, it favors it. And if most of them are to the right, it doesn't favor it. And if most of them are kind of hovered around the middle, as this one is, you say, well, it's not really clear. But again, for we clinicians, we need a nice picture like this. When they're all over on the left side, we like that, and we can tell that is favored. So applying evidence-based medicine to clinical practice requires your individual expertise and all you can muster. The best external evidence, which we are creating here at WVU right now, whether you're doing epidemiology, cohort studies, cross-sectional survey studies, randomized clinical trials, or meta-analyses, you're contributing to the evidence base that clinicians can use every day and taking into account your patient's values. All right. Thank you very much.